So I've had quite a busy morning today so far on Saturday. I saw 3 patients. 2 of them are pediatric patients, and was called about another 2-3 patients more during this time. So it was fairly busy for a dermatology on call. The first patient that I saw had what we call Darier disease, and this is a genetic skin condition that is pretty rare actually, but we do see quite a lot where I'm working in the west of Scotland. You get erosions on the skin because of a certain genetic mutation, and it's autosomal dominant in nature, which means that you can have a 50% chance of passing down to the next generation. So this patient had really bad Darier disease and was admitted to the hospital to get some antibiotics, because people with Darier, they tend to get infected skin quite frequently. So you can not just get bacterial infection, but you can also get repeated or recurrent herpes infection, which is why when we see a patient with Darier disease or any inflammatory genodermatoses, we tend to be a bit more gung-ho in terms of treating any underlying infection. So if you've not seen Darier disease in your clinical practice, it is actually quite good to have a look at photographs in textbooks and online. You get this very classic eroded areas affecting the seborrheic areas of the skin. This includes the sort of the frontal hairline, the nasolabial folds, the chin, the central chest, as well as the flexural areas of your arms and your legs. And if you look closely, the characteristic rash would be quite greasy looking. It looks rough, and you get this papula, which means raised spots, which can be skin colored or yellow, brown in color. A lot of the time you can get crusting or scaling of the rash. The mainstay treatment to help with the inflammatory process is by giving them oral retinoids. The next 2 patients are pediatric patients, which is actually quite interesting because we don't really have a lot of pediatric experience in our training. And so one of the patients that I saw had really odd bruise-like marks on her lower legs, extending up to her thighs. And this only happened quite acutely over the past week or so. And there was no injury involved. Her blood tests were all unremarkable. And I just couldn't really see anything that is standing out in terms of the investigations done so far. With easy bruising, there are a wide variety of conditions that can present this way. So we want to think about common things such as hematological problems, problems with coagulation, low platelets like ITP, certain rarer conditions like inflammation of the blood vessels causing vasculitis. And one of the common type in young children that we see is HSP, Henoch-Schönlein purpura. There are of course other conditions that can cause this problem as well, which is why it is often quite a tricky presentation to dissect. The other patient that I saw was a young patient, a few months old, baby in fact, who presented with this sort of scaling red rash over the occipital or the back of the scalp. Again, it happened quite quickly over the past 2 weeks. And I think it was slightly itchy because he kept touching it. In the pediatric population, they don't really have much clinical history to go with. It really boils down to what the rash looked like and the history that you get from the parents themselves. So for this rash, it looked fairly dermatitic or eczematous, but it was quite annular or round, and it's quite scaly at the periphery. And so whenever I see, a scaling rash that looks a bit annular or round, I think about tinea or yeast infection, which is what I thought in this case. And so I treated the rash on the scalp with a combination of antifungal and steroid cream called Dactocort, which contains miconazole, which is the anti-yeast or antifungal element, as well as hydrocortisone, which is the mild steroid. I just came out of another call with an out-of-hours GP. This is about a breastfeeding mom with this widespread itchy rash. From the description, it does sound like urticaria. The reason why she called me was because the woman was breastfeeding, and so she wasn't sure of what medications to give. For people who are not familiar with urticaria, this is also known as hives, and it presents as very itchy, sometimes widespread, raised plaques or wheals, and this can be quite debilitating to people because of the itch. In terms of treatments, instead of going straight into topical steroid, which we do for a lot of inflammatory conditions, for urticaria, because it's the histamine release from the mast cell causing this intense itch, we try to target the mast cell by giving antihistamines rather than topical steroids. In pregnant women or breastfeeding mothers, there are websites in the UK that can help guide you on what to give or what not to give. So for medications in pregnancy, you can go to the BUMS UK website. And for breastfeeding mothers, there is the Breastfeeding UK website as well. During the call, I had a look at the Breastfeeding UK website, and I realized that antihistamines in general are pretty safe in breastfeeding women. There are very few studies that show low doses of antihistamines in the breast milk, but otherwise it's generally safe. I bought myself a cup of coffee from the coffee shop downstairs just to keep going with my admin because I have been off for the past few days. The admin piled up. I have a lot of letters to sign off. I have emails to reply to, and I also have a few things, bits and pieces left to do as well. The day is still young. Even though I've seen all the patients so far, I am still going to do my admin in the hospital. Just when I was about to leave the hospital for home, I got another call from A&E Pediatrics. So I was called about this baby because she had a widespread vesicular rash since she was 3 weeks old, and now she's around 8 to 9 weeks. And it was quite persistent, slightly itchy, I think, and the rash would leave behind hyperpigmented patches and scales. And so this made us think of this condition called transient pustular melanosis. Transient pustular melanosis usually presents in darker skin types, and as the name suggests, it's transient, which means it's short-lived. Babies tend to present with widespread pustules, papules at birth or within 24 hours after birth. In this case, the baby had the rash when she was around 3 weeks old, and it was quite persistent. And so I had to think about other differentials, such as could this be a viral infection? Could this be a bacterial infection? Other rarer causes like congenital blistering disorders. So what I did was I took some swabs to send for bacteria and viral infections. I also advised the parents to apply some emollients to keep the skin hydrated, and provided a prescription for Dactocort, which is a combination of miconazole and hydrocortisone. Hopefully my diagnosis is right. Time will tell. It can be quite difficult and challenging to diagnose skin lesions and rashes in children when we don't see them that often. I've decided to take a break because, as you can see, the sun is shining outside. It's a little bit cold, but I've got my big jacket on, so I'm nice and cozy inside. My face is a little bit cold, to be honest. And yeah, I've decided to take a break outside work. I've been just going back on some of the lectures that I went to, just to, I guess, do a little bit of reading and revision. I try to look back at the lectures that I've done so that I can remember things better. And I like to sort of make my own notes as well, so I don't forget them. Because if I don't look back, it can be a bit difficult finding the stuff that I wanted to look at again in the future. So I'm going to take a stroll on this road. There is a small hill at the bottom of the road, which I'm going to go up and see the scenery. Literally, we just saw a goose in the middle of the road. The goose was actually trying to cross the road to reach the pond, and all the cars have stopped to let the goose pass, which is quite funny, really. Never really seen anything like that before, but I guess this happens when you live in the countryside. So I'm now back in the hospital after being called about another patient. So this is an older patient who presented to hospital with almost a 2-week history of blisters on her hands and feet. The first thing I thought of in dermatology when it comes to blisters are, is this an infection? So things like bullous impetigo, even scabies, really bad viral infections can cause blisters. Is this some kind of inflammatory process? And in dermatology, we see in older patients bullous pemphigoid, so immunobullous disorders. But then sometimes you get other fancy, rarer pemphigoid-like conditions, such as mucous membrane pemphigoid or cicatricial pemphigoid, and EBA, which stands for epidermolysis bullosa acquisita, where it affects the trauma-prone extensor surfaces of the extremities. And then you think about other things like paraneoplastic, you think about drug-induced, so on and so forth. So there are a lot of things to think about when you see a patient who presents to you with blisters. So in this case, the presentation is fairly typical in the sense that even though she is of the right age group to get bullous pemphigoid, the presentation, however, isn't classic. So for classical bullous pemphigoid, you get this eczematous or urticarial prodromal rash that is quite itchy before the blisters appear. She didn't have that. At the same time, the blisters normally tend to occur on the torso, the trunks, and the thighs and arms rather than the extremities. So again, it's a bit odd that she only developed blisters on her hands and feet. And of course, the blood test for bullous pemphigoid would classically show eosinophilia, which in this case, it showed raised white cell count and neutrophils. So yeah, I find this case fairly interesting just because it doesn't present as a typical bullous pemphigoid case. But nevertheless, I did the same thing as I would with any blistering rash. As I didn't see any blisters, there was no blister to pierce or deflate. I asked for skin autoantibodies. I also asked them to apply some potent topical steroid like Dermovate and a good emollient. So things like 50-50 white cell paraffin, liquid paraffin would do the trick. and also a nice gentle soap substitute because the skin can be quite tender and fragile. So now I'm going to prepare my handover email for tomorrow. Hi guys, I'm now back at home, and just before I got to the front door, I received another call, and this time it's from a maternity unit in another hospital. So we do get calls from, I guess, various parts of the city, not just from A&E, but also from the general medics, the surgeons, pediatrics, and in this case, obs and gynae. The obstetrics doctor was slightly worried about this patient who had just given birth, and she developed this widespread purpuric rash. The most important diagnosis not to miss would be vasculitis, which basically means inflammation of the blood vessels. So fortunately for me, I have remote access, which means I can look at patients' clinical records, blood tests and investigations remotely from my computer. So now I'm just going to go in to have a look at what the situation is. So I just came off the call with the obstetrics doctor and also discussed the case with my consultant on call, had a look at the photographs and looked through the patient's clinical records. What struck me was that it didn't look classic of a vasculitic rash, because for a vasculitic rash, you would normally get the rash starting from the distal extremity, so the feet, before progressing up to the lower legs, the thighs and the abdomen. But for her, it was quite limited and localized to the abdomen and the upper thighs. She had a history of DIC, so we thought, could this be something related to that? She was on injections to thin her blood as well, so whether that's related, we don't know. And in dermatology, every time we see a patient who have had a pregnancy complication or a thrombotic event, we think about antiphospholipid syndrome. Hopefully we'll get to the bottom of it and the rash will resolve over time. Right guys, I have just finished my dinner. It's about 8 o'clock at night right now. So I am actually going to shower, and just fingers crossed I won't get any calls tonight. I hope you like the weekend vlog when I'm on call for dermatology, because a lot of you guys have been asking me to talk about things that I see in dermatology, the patients that have been referred to me when I'm on call. So I hope this is useful. Thank you for watching this video. Please like and subscribe if you enjoyed this, and please also make comments down in the comment section box below if you would like me to make any other videos. See you later. Bye bye.